I'd like to thank Dr. Arabia and the meeting organizers for allowing us to share some of our experience. Maybe before I start on this topic, and I'm really focusing on some granular information. It's almost presenting like a case series that we've had. But maybe we can go around the room, and has anyone in the room at their center used a TAH in a patient with a durable LVAD as a rescue therapy or exit plan? So it's in the thought process. So I think there's some opportunity for some dialogue here as we walk through the presentation and near the end about experiences and so on and so forth. What I'm going to discuss is our experience at VCU, and I'm going to focus really on durable LVADs only, so implantable LVADs, ones from the continuous flow era, so none of these devices are previous pulsatile devices. We'll talk a little bit about the outcomes and where I thought some of the needs for additional information would be helpful. So if we look at the experience at VCU since about 2006 or 2007, since we started implanting artificial hearts, there have been 117 devices implanted. 10 of those were implanted to replace a failing continuous flow LVAD. And the indications were usually multifactorial, but I've included the primary reason I thought the device was replaced. 3 of them were for refractory RV failure. And again, it wasn't, and I'll go into the cases in detail, it usually just wasn't RV failure. It was RV failure and other carnage. 4 were for patients with an LVAD that were in VT storm, and both the RV failure and VT storm were associated with shock. 1 was probably a unique case of someone with a highly resistant infection that ultimately developed a visa infection. And 2 were cases of heart mate 2 pump thrombosis. And it's, full disclosures, this was early in the experience of identifying and diagnosing pump thrombosis, and these 2 cases today may be managed very differently or not exist. Now I want to walk through this table, and I couldn't figure out a clearer way to convey this information, so I created a complex table. And what we'll do is we'll start at the right side, and to give you a sense of eras, since this spans probably 12 years of experience, it is from the earliest implant to the most recent, from top to bottom. And patients were generally primary LVAD implants at VCU, but 3 of the 10 were imported urgent LVADs from nearby device implanting centers. So 2 out of 3 about were our own LVAD patients, and 1 out of 3 were referred by other LVAD or transplant centers. The rows highlighted in red as we go through are patients who did not survive to transplant, and we'll examine why, and the blue are the ones that did. In the 4th column, it says LVAD type, so all of these were continuous flow devices, and predominantly the patients that were implanted with a TAH were also at the time of implant or LVAD failure bridge to transplant candidates. 1 was a bridge to decision, and 1 was a DT patient initially that kind of became a bridge to decision, and then when things didn't go well, suddenly looked like a good transplant candidate. So the duration of time on LVAD support before LVAD failure was generally short. Most patients were on the device for about 3 months before they developed complications that we thought needed replacement with the TAH. There were a few patients with extended support. 1 was the second patient who was on an LVAD for about 1.5 years or 15 months before replaced with the TAH. And the indication for replacement there was she had already had multiple pump replacements for pump thrombosis and was having recurrent events early after device replacement. And the decision at that point was made to just replace with a TAH and bridge to transplant. The reason she did not survive to transplantation was not because of any issue with the TAH implant or TAH-related complication. She had, and this is early in the Freedom Driver experience, after hospital discharge, she developed very high blood pressures, low flows, and failure of the Freedom Driver in the outpatient setting. Eventually, she was seen by EMS, and who were clearly not were undereducated on the management of a TH patient with a cardiac arrest, and attempted to resuscitate her with epinephrine in the field, which worsened the hypertension and led to further low flows. And then she came in at that time with multi-organ failure and unfortunately brain death, but had done very well up until then. The other long-term patient on here was really 6 months, patient number 4, who was implanted for an infection. This was a young man who we probably made the poor decision of implanting an LVAD into in the first place, who was dialysis dependent, 37-year-old, who eventually developed multiple infections, and the plan was essentially to take everything out and replace it with a TAH. He was bridged to transplant and did make his 1-year survival, but eventually died somewhere between 1 and 3 years, and we'll go into that data. So probably someone we would have chosen a different pathway for initially than go this route. Now, as we move to the primary reasons for device indication, most of these patients, and I tried to put what I thought were the primary reasons the LVAD was not successful. The 4 RV failure patients, if we look at those first, all of them came in as either Intermax 1 and 2. 2 of them were referrals from outside hospitals, and 2 were our own. And generally, these were patients who had hemodynamic collapse early after LVAD implantation. So if we look at, and again, I'm sorry this isn't tabular format, but if we look at patients 5 and 6 here, these are patients, 5 was on device for 3 years and was referred from the state of Florida on high-dose inotropes for consideration for TAH implantation, and did very well. And I don't have much data on his preoperative course or clinical characteristics before implant, but did very well and was bridged to transplantation. The other 3 RV failure patients were associated with other complications, sometimes VT, sometimes multi-organ failure, but all of them were in shock. One of them, the one that did not do well, came to transplant after being supported 2 years, came to device therapy after being supported for 2 years with milrinone with the hopes of bridging directly to transplant. Most of those 2 years, she was not listed because of social contraindications, and by the time she clinically collapsed, underwent a VAD implant and a temporary RVAD implant with the hope of bridging her to transplant. Unfortunately, that was not enough to resuscitate her at that time, and a few days later underwent an emergent TAH implantation, but at that point in time was too far along and died soon afterwards. As you can see in the last column, the details of patients, there's a high frequency of patients who were implanted with VT Storm with an LVAD, and one of the things that stood out while sort of calling through the clinical histories was that many of these patients had previous histories of VT prior to VAD implantation, and not VT associated with heart failure decompensation, but just VT on its own as a primary medical issue, sometimes requiring multiple antiarrhythmics, previous history of ablations, et cetera, et cetera. So going back to sort of the flow of these patients, 10 patients, various indications, usually some overlapping reasons of multiple reasons that patients had the device explanted. And here's what happened after the device was implanted. I mentioned that 3 of the 10 patients died. 1 was an unusual out-of-hospital cause, which I don't think would happen now. So 7 out of 10 survived to heart transplant. Of those that survived to heart transplant, all 7 lived to 1 year, and 6 out of 7 were alive at 3 years, and we don't have adequate follow-up after that. And the 1 death before 3 years was the patient with a fairly complicated course, infections, and some end organ dysfunction. And he had sort of a rough course on device and after device. And these were the complications we saw when the patients were on the TAH and how long they waited for transplantation. These wait times for all of these patients were in the previous allocation system, and in our region, at least at that time, most patients were taller, unfavorable blood types that led to TAH implant to bridge to transplantation. And tall blood type O's would often wait somewhere between 6 months to a year as a status 1A in the old allocation system. So that's why the times are considerably long for these patients, even though many of them were in the hospital as 1As. And these were the causes of death, and I reviewed the one in the field. The other two causes of death for patients 7 and 8. Patient 7 was someone who came over in VT storm after having 2 VAD replacements at another hospital, came over on ECMO. Surgery went well, but 2 days later, probably related to something embolic along the course, had a neurologic injury and hemorrhagic bleed and died. 4 days later. And patient 8 was the patient with biventricular heart failure who just did not have the reserve or substrate to survive after TAH implantation. So kind of with this case review, and I'm guessing some of these cases and some of the elements that led our program to implant a TAH are similar to some of the ones that those who raised their hand here considered the TAH for someone with an LVAD and who's not doing well, and the situation's become a little more urgent. I think the two areas that stand out the most is potential opportunities. And I don't know if the opportunity is identifying the patient before you consider LVAD implant or identifying the complication early after LVAD implantation. But the two areas are, of course, patients with ventricular arrhythmias before or after device implantation, and there's growing amounts of data, and I'm not going to go through this in detail. This is just one example of a meta-analysis, and I think something was just published in the last few months about, and clearly this has molded our new allocation system, and people are taking ventricular arrhythmias in the setting of severe heart failure into strong consideration, but clearly having these is associated with poor outcomes after CF LVAD implantation. And we've seen it, and we've sort of relearned the lesson over and over again too, unfortunately. And the second area is certainly identifying when is RV failure severe enough to consider not trying to get by with some of the new tricks and tools that we have, and considering total heart replacement up front. And this is something, I mean, honestly, we've seen from the case series here that we continue to struggle with, even at a center that is fairly liberal about implanting the TAH for a variety of indications. So to summarize, my thoughts on the topic is I think that based on our experience, the device is very effective for salvaging someone who's failing on LVAD therapy. And I think the two primary indications where I think we'll think about it is in patients who have ventricular arrhythmias on device, and the arrhythmias are associated with some decompensation or suboptimal VAD support, and those people with persistent RV dysfunction. It seems like at least the events are occurring very early after LVAD implant, and those are fairly successful cases to salvage. What I think would be helpful is if we collated some of our data of everyone's experience about salvaging LVAD patients, and also better understand maybe upfront what clinical characteristics patients have when we're considering an LVAD that may portend them to having a more catastrophic failure. Maybe not so much of our lighter definitions of RV dysfunction or ventricular arrhythmias afterwards, but enough that leads to us considering or regretting having put the LVAD in. So I'll stop there, and maybe if anyone in the audience would like to share some of their experiences with salvage therapy with the TAH, or thoughts on some of the data or information that I put up, that'd be great.
I got a couple questions for you. I enjoyed your presentation. I know I think you guys can hear me. I know you're the largest center that puts these devices in. You know, Methodist, our experience has been mixed, I have to admit. I mean, we've struggled with it. We're getting burned by right heart failure. I see your guys are struggling, even though you guys are super aggressive up front. I don't want to talk about the theories of right heart failure and all that stuff, but I'm going to ask you a few pointed questions that we struggle with. Number one, do you think dialysis, someone that's on dialysis, not like temporary dialysis, but permanent dialysis, that should be a contraindication, number one? Number two, can you comment on your experience with patients on ECMO that come in to your center? Do you ever put a syncardia and a patient on ECMO support? because I've done it before. I haven't published that series yet, by the way. You're not going to see it. We'll talk later. And the last question would be, one of the terms that I've heard, you talk about rescue syncardia. There's something called a bailout syncardia, which is not a good thing. So just a few comments, if you don't mind. Thank you.
Yeah. So we should really limit the number of questions to one. I can't remember. Yeah. So I'll start with the one.
Just focus on this.
Yeah.
Just quick comment. I don't want to
Yeah,
take a bunch
no.
of time, but
No,
these
let's start with the dialysis
I've
one.
summarized our problems at our institutions. So I want you to just real quick.
Yeah. So the dialysis question is kind of loaded. We are very hesitant to put any device into a patient, LVADs or TAH with dialysis. We have. We just I can't backtrack now. I just showed you a case. So we have, and let's put the LVAD stuff to the side. We've published, and everyone's published, a high rate of infection and stroke, but we still do it. We all do it. Everyone's guilty. The TAH part, I tell you, one of the challenges is if someone has poor renal reserve up front or long-term dialysis, some of the frequent things we see after TAH is we see an even more severe anemia than we would expect, okay? They lose another stimulus for erythropoietin and whatever inflammation people have on dialysis. And we see a higher blood transfusion requirement. So if you can, for something, and then you have all the complications, whatever morbidities that go along with dialysis. I would suggest that in a chronic dialysis patient, a better strategy is dual organ transplantation, someone with heart failure, directly rather than bridging. So ECMO, so in our center analysis, and I think we'll have more information on this, but ECMO to TAH to transplant. ECMO has been associated, and I'm not saying not to do it. We've had success getting from transplant from TAH off of ECMO to transplant, but ECMO is one of the risk factors for us at our institution for having poorer outcomes post-transplantation. So if you follow the journey all the way out, but we do use it, and it is going to be associated with higher rates.
You haven't published anything about it, though.
I'm trying. If you guys review the paper,
well,
just accept it.
I'd be happy to collaborate, but my results are miserable, but I'd be happy to collaborate.
So one of the things that we've seen is ECMO is going to be associated with increased rates of renal failure and dialysis dependence afterwards. Okay. ECMO is going to be associated with a slightly lower survival post-transplant.
Okay, and the last one, I'm sorry, bailout. Because this is one of one of the themes here is patient selection, right? Yeah. So just a few comments on that, because I feel like if we're putting in, as you started before in this meeting, you put these devices in near dead people, they're not going to do well.
So if I had to give, and I know Francisco has some data on this, but if I have to give 2 or 3 clinical characteristics where we would not put not put the device in. Number one, older patients. If you're older than the age of 60 or 65, think twice and think long.
Okay.
Number 2, if you're going in with a late stage of RV failure, I'm talking about where albumin's very low and you have a very malnourished patient, and you're trying to bail them out of a failed bridge, they're likely not going to do well for a variety of reasons. We've had multiple failures of this phenotype, and I said 3, but I can only think of 2. But those 2 scenarios, I would avoid bailing anyone out. But otherwise, yes.
How long will you take your patient? Will you let your patient remain on ECMO before you decided to switch on TAH? Because at least in Canada, up there, we have the possibility to have the emergency status for our ECMO. And one of the major discussions we have with our cardiology colleague is, well, okay, let's wait another 24 hours and see if we have a donors. And finally, we end up after 10 days on ECMO, and okay, that's time, let's go to the TAH. Well,